Hey guys, it's me, Dr. Samina Rahman, Gyno Girl. Today we're going to have a good discussion, a short discussion about what happens when either you grab your mirror and you look down there and you can't find your clitoris, or your doctor or healthcare professional is examining you, which kudos if they're doing that, and they can't find your clitoris. So what does that mean? What does it mean to have clitoral adhesions or clitoral phimosis? So let's get at it. Hi guys, it's me, Dr. Samina Rahman, Gyno Girl. For those of you that are new to my channel, I'm a board-certified gynecologist. I have a solo practice in downtown Chicago. I take care of patients with vulvas who have sexual dysfunction, perimenopause, menopause, a variety of other gynecologic conditions, as well as vulvar dermatoses and other issues that they're facing, and we try to get you to the best quality of life possible. I'm a mom of 3, I live in downtown Chicago, and I'm trying to get better at this YouTube thing, so we'll continue to try to put out weekly videos. Last week I was suffering from laryngitis, so I couldn't do anything otherwise. It was very bad. So today we're talking, also please like and subscribe to my channel. Today I'm going to discuss a condition called clitoral adhesions. Where's my clitoris? I always encourage my patient to take a mirror and look down there. In my office, I'm always presenting them with a handheld mirror to look down there to see what I'm seeing. What we found in the sexual medicine literature that's out there, which is not a lot, but what we do know, Dr. Rachel, one of my colleagues and friends, did a study that about 22% of the patients that presented to sex med clinic did have clitoral adhesions or phimosis. And there was a different study, I think, that showed about 33% of patients, college-age students, that presented had clitoral adhesions. So, we're looking at roughly a fourth to a third that might have it. Whether or not it's clinically significant is not always the case, but these are documented. So what are we dealing with here? This is my vulva puppet. I've showed you on different videos. So my vulva puppets here, remember labia majora, labia minora, clitoral hood or prepuce, and then the clitoral glands. And so what happens is you can have slight adhesions or phimosis. We call it mild, where maybe only 25% of the clitoral glands is covered. When it becomes 50 to 75%, that's pretty moderate, and severe is when only 25% of the clitoral glands is visible or less. What we're trying to be able to do is if you retract the clitoral hood, you should be able to get to the corona and visualize it. When you can't, that means that there's phimosis. And I always tell patients when they have phimosis, but a lot of times, they have no symptoms. And so what are the symptoms of clitoral adhesions or clitoral phimosis when you can't see your clitoral glands? One of the big ones is clitoral dynia, which is pain in the clitoris, which is, no fun. It can be pain on touch, it could be pain all the time. Another symptom is sort of muted or absent orgasms. Some patients will have, sexual pain. Some patients will have, generalized clitoral irritation. What forms here is sometimes when you have the sebum that's produced here, you get schmegma that forms underneath the hood. That schmegma can then cause these keratinized pearls to form, which if you think about having sand in your eye, think about having like a little rock under your clitoral hood, that could be very uncomfortable and painful. Those are things to consider when you're having those conditions. I've had patients that have had sort of infection of this or balanitis secondary to, either a pseudocyst or other things that have formed. Those are all sort of things that, I've seen in my office. And when we think about sort of what is the cause of all of this, or what is it associated with? Let's talk about that. So we think, clitoral scarring from either injury to the clitoris, or for some patients that have had sort of female genital cutting, that can be something that they experience, the scarring that then forms these adhesions. There are patients with certain vulvar skin conditions like lichen planus or lichen sclerosis. Particularly lichen sclerosis, we see it more often, I think, that will have these adhesions or scar tissue that form. So that's like an inflammatory skin condition. Other causes of inflammation, such as, chronic yeast infections or infections of the skin, can potentially lead up to that as well. I will do a separate video on lichen sclerosis and inflammatory vulvar skin conditions because I see quite a number of those in my office as well. So we want to make sure that we discuss that in a video. And you can tell me if there's other things that you think we should be discussing. I'm happy to do that as well. Some patients with persistent genital arousal disorder, I did a video on that, might have clitoral adhesions. That's the first region we look at when we're thinking about the diagnosis of PGAD. So that is something that I always look for in those patients that have persistent genital arousal. The other thing to think about, and remember I did that video Clitorology 101, and so that was sort of a discussion on, why we haven't studied the clitoris enough, why it's important to know your clitoral anatomy. So please, check out that video if you haven't done that as well. I think there might be some hormonal mediation to what happens to the clitoris and the adhesions. For instance, patients that are in menopause, perimenopause, postpartum lactating, have diminished estrogen, diminished androgens, then this might contribute to clitoral atrophy, which may then cause adhesions potentially to form. We don't know exactly if that mechanism is true or what's going on. We're still studying some of that in our literature. Additionally, patients that are on birth control pills, when you take a birth control pill, it's metabolized through your liver. Your liver makes a protein called the sex hormone binding globulin. It binds to your androgens and your testosterone, which if you're on birth control for acne, that makes sense. That's why you're on the birth control and why it works. But in the same respect, it diminishes your androgens, which your clitoris needs. So, it may be contributing to some of these adhesions as well. Again, we're not able to visualize all the way down to the corona, so these adhesions are there. Sometimes they have no symptoms. Sometimes they have the symptoms that I described above. And we think it's related to some of those conditions that I just discussed as well. It could just be something like clitoral pain, which sucks, honestly. PGAD, like I said, clitoral sensitivity, or blunted or muted orgasms, or even arousal issues like we discussed. So those are some things that might present clinically. So if you have any of those symptoms, take a look down there and see if this is something that you might need further investigation. Please see a clinician that has an expertise in sex med that can help you. Remember www.ishwish.org. I'm on many committees. I'm on the board of Ishwish along with these other board members. So I do advocate for this organization, and no, I do not get paid by them. So I'm just a big believer in the organization, and I love what they do. So that's sort of what we think is happening with associations or pathophys, as well as the symptoms you may be having. So what do we do about it? So traditionally, clitoral adhesions, may have been treated with, steroid cream, especially if it's related to lichen sclerosis, ointments such as estrogen, testosterone ointments in the past, petroleum jelly, but we also are finding that there's an office procedure we can do called clitoral lysis of adhesions, where, basically if this is your, adherent clitoris, you can numb this area with benzocaine, lidocaine, tetracaine ointment, and then take some instruments to unroof this and remove any of the keratinized schmegma, those pearls that we see that might be causing the symptoms, or even just removing the adhesions and seeing how it looks and hopefully improving your sexual function. And we're still trying to figure out the best post-procedure ways to deal with it. So whether it's using the steroid cream or ointments or petroleum jelly, again, the data has not been fully generated, so we're still doing a little bit of everything to see what helps benefit the patient the most. Should be retracting at home as well, retracting that clitoral hood so that you can see the glands. So that's sort of a minimally invasive sort of office-based procedure. And then for patients that sort of have complete phimosis where you can't even see the clitoris, it just looks like this, then we will take patients to the surgical suite, an operating room, and do the dorsal slit procedure, which is similar to patients who have a penis who have a situation with phimosis of their foreskin. You do a little dorsal slit, you make a little incision all around the hood, you try to retract it up, you try to do the same thing where you kind of take an instrument to undermine underneath the clitoral hood to try to lift it up. You have to put a couple sutures in to make sure that it doesn't close back up. Very minimal surgery that's done, but it is done under anesthesia as well as in surgical suite or operating room. So that's sort of clitoral adhesions or phimosis in a nutshell. Quick little video today, but I want to just continue on my clitoral journey from Clitorology 101 that I did before. I'll continue to do something. I'm going to talk about clitoral priapism and some other conditions in future videos. I'm going to address some sexual pain issues around vulvodynia and vestibulodynia. So we'll get some videos on those as well. But if you have any comments or any suggestions about what you want to hear, I'm happy to address those as well. And thank you for joining me today. More to come, and I hope you have a great day. Take care.